So yes, to begin with, I would like to acknowledge the team that helped work with us on this project, led with some researchers from the Mayo Clinic. And 6 minutes goes by very quickly, so I'm going to jump straight into it. So I think we can all appreciate that one of the most important skills for any health professional is to identify what problems you can treat and what problems are best treated by somebody else. And this is why we have referrals. However, not all referrals are equal. We are doing well when referrals that should be made are made, or when we avoid making unnecessary referrals. On the other hand, sometimes referrals are made when they really shouldn't be, or they're not made when they are required. When this happens, this results in resource waste and suboptimal care. We think that CPD is one potential way in which we can optimize referrals. And to this end, we ask the question, what is the association between physician CPD and referral patterns? And secondly, what features of CPD are associated with optimized referrals? And so we conducted a systematic review where we screened over 3,000 articles and ended up including 31. Of these 31, we compared CPD to these articles compared CPD to no intervention in 27, and only 4 of these articles compared CPD to another form of CPD. And these articles also represented about 15,000 physicians or 400,000 referral events. So going into our results now, what you can see here is a forest plot of the studies that specifically compared CPD to no intervention when the intention was to increase referrals. What you can see from the black markers where the squares are, that most of the studies favored CPD over no intervention, but the confidence intervals were quite large around those estimates in some studies and smaller in others. When interpreting these results, there's a few things to pay attention to. Firstly, there was a large heterogeneity in terms of the clinical specialty of participants. So, some of them might have been in general practice, others in cardiology. There was also a large heterogeneity in the clinical topic targeted by the CPD, as well as the educational modalities used. Overall, the pooled risk ratio was 1.91, which indicates a 91% increase in referrals following CPD compared to no intervention. And so really, what's the bottom line? What we found in this study was that CPD does indeed improve referrals when compared to no intervention. But due to the lack of head-to-head studies, it's really not clear what types of CPD are more effective than others. If you are thinking about conducting studies using referrals as an outcomes, there are 4 things that I think would be useful to think about. Firstly, as I said before, we need to conduct more head-to-head interventions. As a field of research, I think we've generally agreed that doing something is better than doing nothing. But what we really need to understand is how to do that something better. Head-to-head interventions are one way to study this, but I'd also like to hear from you about what other ways we might be able to study and identify what types of CPD are more effective than others. Secondly, when looking at referrals, we need to specify the intended direction of change. Sometimes the goal is to increase referrals, and other times our goal is to reduce them. However, in the studies that we included, this was not always explicitly stated, and therefore made it really hard for us to understand what the study was trying to achieve. I think this will also lead towards understanding how to make CPD more effective, as understanding the direction of change will have implications on the underlying mechanism and theory. And I might also suggest that the theory of starting a behavior might be different to the theory of stopping a behavior. Thirdly, I believe that it's also important that we evaluate the appropriateness of referrals. As I said at the very start, not all referrals are equal. And even if we intended to increase referrals, and they did increase, it doesn't mean that those increased referrals were actually high quality referrals. In this review, only 7 out of the 31 studies measured the appropriateness of referrals. And fourthly, I think it's also important for us to consider measuring referral completions. Just as educators, our goal is not to teach students, but for students to learn. In the same way, the goal is not to give out referrals, but for those referrals to be completed and therefore for the patient to receive that care. And again, only 9 studies in our review measured referral completions. So in conclusion, given that I am speaking to an audience of people who are likely interested in CPD, I'd suggest that you consider referral as an outcome in your studies, and also in the sense that this might be relevant to health services or governments who might be funding your research. Thank you.